everybody. Recording live from somewhere. This is Zach Couples with episode number 92 of the Movement Debrief. And tonight, folks, this one's for the ladies. We're going to talk about, too much traps. What happens if you're reaching and you're trapping all day and night like your favorite rapper before he got famous? We're going to talk about how to reach so you get less neck. We're going to talk about hand health. What are the components that go into having a healthy hand? What types of grips should you do? Are there any PT or training interventions that are worthwhile for hand stuff? I'll give you the answer. Last but not least, we're going to talk about good old arthritis. Is this always correlated to pain? Is it a big deal? I will give you the answer to that because these are questions, people, that have been asked by the people. They'll be answered for the people by this people right here, fam recognized fam. Without further ado, let's debrief, shall we? The first question comes from my dude, the legend himself, Gerard. And here's what Gerard asks me. Any cues to get the traps to relax when reaching horizontally? I've come across a few people who have trouble with this. Gerard, great question. Let me do the best that I can to give you an answer on this one. So first we have to consider, well, all right, so, you're all trappy and you feel your neck going all wild and crazy when you're reaching. Why is this? Well, I'm glad you asked. A lot of it has to do with the orientation of the upper thorax. For example, if my thorax, well, let's say normal. Normally when I reach forward, the scapula, and one of my scaps suffered a acromion fracture. So sawbones, you gotta get it together. But anyways, the scaps should slide along the ribcage. They should rotate around the ribcage as you reach your arms forward. That's protraction, which is a combination of abduction and internal rotation. So we should have this normal sliding, this normal rotation along the thorax as you're reaching forward. If that's all well and good and you have movement options available in the upper thorax, you shouldn't have any neck issues when you're reaching. Here's what happens though. If I develop a scenario where the pump handle is more depressed or I have an exhaled front side of the rib cage, you could even have this with some compression posteriorly, but predominantly if the thorax is tilted anteriorly. Now what happens when I reach is I run out of room for the scaps to protract. They can't glide along the rib cage on the lateral aspect. I run out of room. The neck muscles, predominantly levator scap, maybe a little bit upper trap, but there's really not much attachment of the upper trap to the scapula, actually. It's mostly to the clavicle. But when I do that reach, now these guys have leverage because, I can't abduct and IR any further, so the only option as I reach is to elevate the scapula, which is what is getting you your neck tension when you do a horizontal reach. So can't slide, only place I can go is up. So then you're probably wondering, well, what's the solution? Here's the solution. The solution would be getting individuals to reach while keeping the chest parallel to whatever surface they're reaching for. So in this case, if I'm reaching horizontally, I should be keeping my sternum parallel to the wall. If you're doing a push-up, your sternum should stay parallel to the ground. Now, just cueing that may not be something that can impact that. You may have to first restore dynamics within the anterior thorax. How do you do that? First thing, well, actually, coaching the forward reach if I'm someone who's a narrow, because, well, let me back that up. So before I drive pump handle mechanics, I have to establish lower thorax position as well as pelvic positioning. Because if I can stack my thoracic and pelvic diaphragm, that gives me a base to ensure that I get multidirectional expansion in the upper thorax. If I have a scenario where these two things are not aligned, so to speak, I hate using that term, but I have a mismanagement of pressure in the abdominal and the pelvic region, that's going to influence where air goes. If I'm more in this arched orientation, I may have a harder time getting air posteriorly, as an example. So you have to get lower thorax first. If I'm someone who's a narrow infrasternal angle, if you don't know what that is, I'll link it in the show notes. Hopefully you've been following me for a minute and you know, but if, hey, maybe you're a noob, so and nothing wrong with that. Infrasternal angle debrief. But if I'm someone who's a narrow infrasternal angle, you may start with actually a forward reach, which you would have to cue the chest parallel. I would pick activities where they best do that. I have some of my favorites where I start these people. Usually that's either a position where they're on their back reaching forward, and I'll link that in the show notes as well, or I'm having them do a rock back position, which is also a great activity. Pressing through the forearms so the lever at which they have to reach is reduced. So it makes it easier. Those would be starting positions for someone who's narrow. Someone who's wide, the arms are overhead. Jason and I will mention that. For someone who is wide, throwing the arms overhead will actually improve both pump handle mechanics, which if someone has a depressed sternum, that would be something you'd want to drive, as well as the bucket handle mechanics that are desired with the wide infrasternal angle. So really, nothing changes if someone is wide. You're still starting them with arm overhead positions, whether it's in a 90-90 orientation on the back or you're doing a side lying activity with a reach. Anything like that is worthwhile and will probably take care of the neck tension that individual is getting when they're performing a reach. Back to the narrow case. You do a forward reach, you've coached them into easy activities to where they can establish reaching while keeping the sternum parallel. From there, you may need to go and improve pump handle mechanics. You would go after this when you have normal respiratory variability in the lower thorax and in the pelvis. What does that look like? When you're measuring infrasternal angle, does the rib cage move laterally and superiorly or outward and upward? And do you have a decent amount of hip extension? Those would be the two measures that would signify that you probably have a decent amount of variability. And if you go with an activity, you start raising the arms overhead, they don't lose the stack of the thorax over the pelvis. Once you've done that, that may improve some of the dynamics in the anterior chest wall, which may make reaching easier. Once you have those things for someone who is narrow, then you can start getting all types of wild and crazy with the horizontal reaching activities that you're doing. So you've coached them on the easier activities, then it's simply a matter of progressing them to more challenging activities. So if you started with rock back, get them in quadruped, maybe you're doing bear push-ups as a progression, which I'll link in the show notes. I really like those. Working towards any type of press. And that's really the crux of it, and that's the progression that I utilize when we're talking about someone who is getting a lot of neck tension when they reach. Say you've done all that, they're able to keep the chest parallel, and they're still getting some neck tension on the reach. You may have to work more at the distal component, which would be cranial cervical stuff. Things that I like for this, if you're into myofunctional therapy, I'm hoping to learn a lot more about this year, but that might be a great way to loosen up some of the tissues surrounding the neck. In fact, I found that to be the most impactful with just a little bit that I've been experimenting with on my clients. Also, making sure that chin position is more into OA extension. That can be another thing that you can use, because what that will do is when you move into OA extension without lower cervical extension, I'm talking just about the head. So think CPR position. That will depress the hyoid bone, which will allow the infrahyoid muscles, which many attach to the sternum, to pull the sternum upward. That can also enhance the pump handle mechanics that you need. You do those things, and you ought to be in business, and you ought to be able to reach more effectively horizontally with less neck. To summarize your wonderful question, Gerard, keys: keep the sternum parallel to the surface that you're reaching for, because if the sternum is more depressed, neck muscles get more leverage to reach, because the scaps, that's the only direction that the scaps can move effectively. Ways to do that: start in regressed positions. You'll want to start with horizontal reaching and maybe a rock back or a 90-90 position. If you're wide, doing 120-degree flexion reaches ought to be quite useful because that should take care of lower thorax and pump handle mechanics, because pump handle is what you're likely going to have to go after. Once a narrow has established the ability to stack the thorax over the pelvis, then you can start reaching overhead to improve pump handle mechanics. While you're doing that, continue to progress to more complex and challenging positions that you would do the horizontal reach. And if that still fails, you might want to start looking upstairs. This would include doing myofunctional therapy or even temporomandibular stuff, as well as making sure you have upper cervical mobility. Gerard, great question. I like it. I like it a lot. The next question comes from Angus. And here, before I dive into that question, Jason on Facebook asked a quick question. He said, can I ask your view on why you dislike the term alignment as you mentioned? So let me ask that real quick. There's a few reasons why I don't like alignment, and let me list those out for you. So first thing, patients can misconstrue this quite effectively. Or actually, on a fundamental level, I think that alignment is not what we're searching for. What we want to have is options and the ability to move in multiple directions. And we're not static creatures. We're always moving. Even when I'm sitting here chilling like Bob Dylan, there is movement actions going on in various regions of my body. I'm having unconscious shifting. I'm swaying back and forth. So if we're constantly in motion, how is it that we can be aligned? So I think from that standpoint, it implies that we're static creatures, because when we're talking alignment, that's usually in regards to static objects. What I think is more important is having the ability to move in multiple directions, and that's just being able to do so dynamically and at rest. We should have all of the movement options available at all of our joints. Moreover, I've seen a lot of places and cases and patients who I've worked with who've worked with practitioners who emphasize alignment, and many times that can be associated with negative connotations for the patient, or they can turn that into a maladaptive belief, because then they're hyper-focused on, oh, I need to make sure I keep this tucked position, or I need to make sure I sit up straight, or I can't sit any other way but up straight, otherwise I have problems, I'm going to have problems. And I just want to avoid that being an issue at all costs. And that's really why I don't like alignment. Fundamentally, it doesn't make sense to me, because we're dynamic creatures, and it can lead to a lot of maladaptive beliefs that we do not want our wonderful people that we are working with impacted by. So, great question, Jason. And John, what'd it do? The next question comes from Angus, and here's what Angus asks me. Hey, Zach, I was wondering what your thoughts on hand health are. What sort of range of motion the hand should have, and how should we go about restoring this and keeping healthy hands? Angus, this is a great question. So, a lot of hand health, it comes down to a few different things. So you have to have range of motion, obviously, in your hands. That would be one thing. I'll go into that. And the other thing that is important with hand health is, can you assume multiple grips and grip super heavy things? Now, let's go into the ranges of motion available at the hand. I'm going to exclude the wrist because, it's important, but let's talk hand specifically. Maybe wrist will be another debrief at some point. So, hand motions. You should be able to make a fist. That's one thing. If that's going to show that you have adequate range of motion in the fingers, and then if you can wrap the thumb around, that shows you have adequate range of motion at the thumb. You should also be able to straighten your fingers all the way. Same reason. That just shows you have full range of motion in the joints of the fingers. If we zoom in and dive into the fingers a bit more, you should be able to do two different actions at the fingers. This is called differential tendon gliding. The fingers, when they flex or they bend forward, there's two key muscles that impact movement. You have flexor digitorum superficialis, and you have flexor digitorum profundus. Each of those muscles have different attachment points on the hand. in order to recruit flexor digitorum superficialis only, you will want to make a fist where you bend at the knuckles, or the MCP joint, and you bend at the next joint, which would be your PIP joint, like so. So I'm keeping the tips of the fingers straight and bending or flexing the rest of the joints in the hand. So that's like a hook fist is what they would call that. So that would be for flexor digitorum superficialis. Flexor digitorum profundus attaches to the distal part of the hand. For that one, you want to keep your knuckles straight, and you're going to bend the PIP and the DIP, so the top two joints in the fingers. And that would be for flexor digitorum profundus. You should be able to demonstrate all of those ranges of motion. If you can't, you might want to work on that. And not just with the wrist in a straight position, working on these different fist positions, but you'll also want to work in the wrist extended, because that changes the gliding mechanics a bit differently, as well as the wrist in a flexed position. Shout out to Brian Chung for that little trick, because that's been a doozy, and I'll link him in the show notes. He's a really brilliant hand physician, does hand surgery, and he taught me that. So kudos to him. So yeah, those are some of the ranges of motion that we need in the fingers. In terms of the thumb, aside from being able to give the Siskel and Ebert thumbs up, rest in peace to both, you should also be able to perform opposition. This is critical for when you're gripping things. Opposition is being able to touch the tip of the thumb to all the fingers. The one that signifies the most excursion would be the pinky. So you should be able to touch thumb tip to pinky and then slide down so you're touching where the callus would be, or the base of the knuckle. That is maximal opposition. You probably should be able to do that. If you can't, same principle. I would do working on opposition both in the wrist extended, wrist flex, and wrist neutral position. Those are the big hand ranges of motion. So we have opposition, which is the last one I talked about, making a fist, making sure you can straighten your fingers, and you got the claw fist, or the straight fist, and the claw hand. You do those things, you probably got good hand health, you got good hand range of motion. On to grip strength. Grip strength is super duper important. And the reason why grip strength is so important is because it is linked to mortality, among other things. It's just a great marker for health. Now, there's many grips that you can go after to ensure that you have adequate hand strength. And I forget, there was a great book that had all of these different grips. And if I find it, I'll link it in the show notes. But no promises. Let me see if I can find that grip book. But before you even worry about grip strength or doing specific grip work at the hand, you got to make sure that you clear up everything else proximally first. There's lots of research out there showing that if you perform manual therapy or exercise to the neck, that can actually improve grip strength. So I think it behooves us to make sure that we have all of our movement options available in the ventral cavity region as well as the appendages. Once you've done that, you still want to get a little wild and crazy with the grip. Let's get into it. First grip would be making a fist as hard as you can, so you should be able to do that. This type of grip is useful if you're picking up a barbell or grabbing most things. So we should be able to do a fist grip fairly hard within, if you have like a dynamometer, you can test grip strength, and that should be, there's normal values that we have based on age group. You probably should be within that group. And I'll, if I can find those normative values, I will link that in the show notes as well. So we have fist grip. You have pinch grip. You should be able to pinch pretty hard with all your fingers. I believe there's normative value on that as well. Those are two grips. Uncommonly talked about grips. You have what's the word I'm looking for? The lumbrical grip. So where your hand looks like a duck. This would be a grip you would use when you're gripping a book, like so. That's basically loading the position for the lumbricals, but also the flexor digitorum superficialis. So gripping books is also a very useful skill to have. I've done activities for myself where I've gripped several plates in that position and walked with them, and that's super challenging and something I would consider trying, something maybe to mix up in your carries and your training. That's a great grip to use. Utilizing the fat grips on bars, that's also great. It's kind of like a crush grip, which I think is very useful because now you're emphasizing more FDP when you're doing that, because you can't get as much MCP or knuckle flexion with that. That's also a very useful grip. You can also, if you don't have fat grips, doing a hex grip on a dumbbell, so grabbing the top of a dumbbell and holding that and walking around, trains the same thing. I think that grip is very useful. And yeah, those are really the big grips that you should work on if you want to improve your hand health. The captains, if you need to improve fist grip, the captains of Crush make awesome progressive grip strength machines that you can work with. For the lumbrical grip, I just grip several plates, walk with that. For the Crush grip, you can use a hex bar or the end of a dumbbell, or use the fat grips to train those things. And a lot of times, if you can do those things periodically in your training, you can see some nice changes in grip strength and subsequently hand health. And I think it's an important thing that we probably don't train too much. And if you think about in training, when we're gripping dumbbells and barbells, really what you're getting is maybe a little bit of crush grip, but mostly fist grip. And we don't really work the other grips. And I think that's probably something that's neglected and we should pursue. And there's lots of other cool things you can do to improve hand health, like learning how to rip open phone books and stuff like that. All of that is very useful for improving your hand health. So to summarize your great question, Angus, you need to be able to demonstrate range of motion in the hand, which would include the 3 different fists that we talked about. You should be able to move your thumb in all directions, give the thumbs up, and do opposition to the base of the pinky. And then you should be able to grip lots of wild and crazy things. Fist grip, pinch grip, lumbrical grip, and crush grip. Those 4 things, if you train them, you're probably going to have super strong hands. You're going to have that old man strength or old woman strength, whatever you want. And you'll probably be in business with your hand health. Great question, Angus. Now, if you're wondering, well, okay, Zach, you kind of glossed over, well, how do I improve the movement options and the strength in my arms and in my trunk, my thorax? Or maybe, hey, I have this trap stuff where I'm reaching, I got some issues, and I want to know what type of activities I can use to help myself or my clients be able to perform horizontal pressing or reaching without issues. Well, I got an answer for you, and that answer will be at Human Matrix, my seminal seminar. Ooh, I like a little alliteration right there. Where is it? A few different locations this year. August 24th, 25th, Vancouver, British Columbia. Next week, Saturday and Sunday, if you are in the Vancouver area, or if you're not, man, you want to go to a cool place, you want to go learn a dope seminar, hang out with some great people, you probably want to give that a shot. Please sign up for the Vancouver seminar. October 5th and 6th, Boston, Massachusetts, which is selling quite well. I think that's going to have a good showing at that one. November 23rd, 24th, New York City, again, round 2. Sold out the first one. Got to take care of the peeps who couldn't make it. December 7th and 8th in Orlando, Florida. And last but not least, we'll be in January 25th, 26th in Scotts Valley, California. There will be others. Stay tuned. I'm still working on the details. The last question comes from Lucy, a.k.a. Lou Hen. And here's what she asks. Zach, Maji, good to hear from you. A lot of people will always default to blaming pain, all the pain in their body, on arthritis. Does arthritis correlate with pain at all times? Lucy, this is a great question. Let me answer it for you. What is arthritis? That's probably the nebulous thing, because if you ask people what arthritis is, you'll get a myriad a myriad amount of answers. People will think, well, it's bone on bone. I'm getting crushing in my joints. It's whittling away. Lots of nasty things. And no one ever explains what arthritis is. If we look at the root of the word, arth is joint and itis means inflammation. So arthritis is simply inflammation of the joint. It is often associated with age-related changes. Now we have to ask ourselves, how often is arthritis related to pain? There's some research out there in various places of the body. A lot of this is done in low back pain, but many different areas. You can search this stuff pretty readily. Anywhere from 30 to 80% of the asymptomatic population has abnormal findings on imaging. That includes X-ray and MRI, and that range is quite wide because there's many different studies looking at imaging findings on asymptomatic populations. So clearly, we have a case where arthritis and pain don't always go together. Now, that being said, in all fairness, if you do studies on people who are in pain and you look at their imaging, those individuals are more likely to have abnormal findings on imaging as well. So we have a scenario where, well, okay, we have asymptomatic population, certain percentage of them presents with degenerative changes or arthritis. We also have a symptomatic population who seems to have a greater predisposition to having some of these changes. So what is the difference maker between these two things? And there's actually some interesting research coming out on the role of the synovium in osteoarthritis, intriguingly. And I'll link this really awesome study in the show notes. I'm like highlighting the snot out of this, and I need to reread it because it was really well done. And what they looked at was what's going on with the synovial fluid. Because in arthritis or degenerative change, you have a reduction of the joint space. Well, how does that happen? Maybe what's going on is the synovial membrane, which is the membrane that keeps the fluid between your joints intact, becomes more permeable. And it lets out some of the molecules that contribute to the thickness of the synovial fluid. Thicker fluid means better lubrication of the joints. So if those molecules that make the synovial fluid thicker starts to thin, then we have a problem because now the space between those bones is reduced. And in the worst case, you could potentially have bony contact, which is no bueno because that's problematic. That's not allowing for movement options to be available, and that could be a contributing factor to pain. The thing is, though, is not everyone who has osteoarthritis or arthritis has changes in the synovial membrane. Maybe, and this paper posits this, maybe that's the difference maker between those who are symptomatic and those who are not. We have to go beyond the joint and the bone, but really, in this paper, all of the tissues are impacted when you have degenerative changes. And there may be certain tissues that lead to a painful scenario and certain tissues that may not. Pretty interesting stuff. So what other markers, because it's really hard for us to measure what's going on in the synovial fluid, would you look for in someone who has arthritis that is maybe a problem? The biggest thing for me as a clinician is if I see someone who has severe movement limitations, meaning they have minimal motion available in the joints, or maybe they have really hard abrupt stops. Like I have a guy right now, pretty certain he has osteoarthritis in his hips. And his range of motion at his hips is as follows. Hip flexion is about 60 degrees. Normal should be 120. He has maybe 20 degrees of external rotation, normal 60, and he's got about minus 20 of internal rotation. Now, he's asymptomatic, but clearly that man has had some bony changes go on in his joint. And maybe he's an individual who has minimal change in the synovium, but he has changes in the joint surface that's impacting movement. So if you have someone who presents like that and they have pain, then we have a scenario where maybe we have to, and on top of that, we're not getting changes with some of the conservative measures that we would use. Because even, maybe not that guy, but people who have limitations in multiple directions, they can have improvements in motion. So maybe those individuals can join the asymptomatic population of those who do have arthritis. But if you have someone who has pain, has multidirectional limitations in motion, and they don't get better with conservative treatment, that's when these arthritic findings probably matter. But if you have someone who has pain, but they don't have those movement limitations, I would say do what you can. See if you can get them mo better. And maybe they can join the asymptomatic population. And if you have someone who has crazy limitations and they don't have pain, like my guy who's got no hip motion, well, I had a conversation with him, and I've seen him twice since I've been in Page America. And they've both been for knee pain. And these things got better with time and graded activity, but I did make him aware because his mobility is limited by the lack of motion. And we weren't getting any change. And I just said, hey, maybe you need to get some imaging done on your hips because I think you have something going on there that's creating these crazy limitations that you have. And maybe even though he's asymptomatic, his loss of his ability to move, like when he stands up, he has to cross his legs to stand up. I mean, it's crazy. Maybe that individual, even though he's asymptomatic, needs surgery to improve function. And the only way you'll know that is if you have imaging. So to summarize your great question, Lucy, arthritis, it is not always correlated with pain. Maybe if there is a disruption in the synovial membrane and the synovial fluid, then you have a scenario where those people may be more predisposed to having pain. The key when we need to act with people is you need to have symptoms, you need to have a loss of movement, and you need to have a failure of conservative treatment. By having those three things, that's probably when arthritis is actually impactful and maybe needs a more aggressive treatment. If you are missing one of those three, maybe you don't have pain, might not be indicated to do an aggressive treatment like surgery. If you have pain but you don't have the movement limitations, you should try as many conservative measures as possible because you could potentially fit into that asymptomatic crowd. If you have pain and movement limitations, yeah, you probably need surgery. Or limitations in imaging finding, that would be something where I would probably go with a more aggressive treatment. So, Lucy, thank you so much for your great question. And I think that's a good stopping point for us tonight. I want to thank all of you beautiful, sexy, outstanding people for tuning in. If you want to learn more about some of the stuff that I've talked about, go to zachcouples.com. I got a gang of stuff on there in terms of in all different facets of health and performance. Definitely check me out. While you're there, you'll want to subscribe to the newsletter because you can get about 5 hours of free talks on both pain and breathing. You'll get a free acute to chronic workload calculator. You'll get weekend goodies every Friday, all types of good stuff. Once you've subscribed to the newsletter, I also offer 3 services. Maybe you are that individual who has a hard time reaching without neck. Or maybe you've been told you have arthritis and you're wondering, hey, you know what? I wonder if I improve some of the movement stuff Zach's talking about, if that might help me improve my life. Well, that's where the movement consultation comes in. Here's what we're going to do for you. I'm going to take you through a full evaluation. We're going to find out what areas you can and cannot move, see if we can improve those areas. And a lot of times, for the people who I work with online, that leads to improvements in pain, performance, all types of wild and crazy stuff, just by impacting the movement side of things. Maybe you want to learn how to do that with your people. Well, that's where the mentorship program comes into play. What we'll do is we'll have a back and forth discussion about your clientele and how some of these principles can apply to the people you work with. And a lot of times it's very tough to see where the holes are in your game if you don't have someone looking at the forest through the trees. That's where I can come in to help you. And also, too, if you are a coach or a clinician, a great way to help enhance your learning is by going through movement consultation either with yourself or by going through with a client together. And a lot of times with that, we can lead to profound improvements in one's ability to execute some of the stuff that I'm talking about. If you want to take that to the next level and work on performance, whether it's muscle gain, fat loss, or you're post-rehab and you want to start working out so you can get your life back, that's where the online training component comes in. I will take the movement consultation that we did with you, and I will design a program specifically tailored to your needs, movement-wise, with your fitness goals in mind. Once you've scoured ZachCouples.com, you'll want to go to iTunes and Stitcher and search for the Zach Couples Show. Because guess what, folks? There's 91 other debriefs. And, well, you know, some of the earlier ones, yeah, you know, it's kind of a little scared. Ooh, I'm on camera. What should I do? You might want to listen to those instead. Once you've done that, find me on social media. I'm all over the place. Facebook/ZCouples. The Twitter handle is @ZCouples. I'm on that Instagram, baby, @Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And last but not least, go to YouTube. There is a gang of exercises on there. I'm constantly updating my YouTube channel based on whatever activities work for the people who I work with. Thank you so much for tuning in. You've been a wonderful audience. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.